This recording will cover part 2 of Alzheimer's disease. Priority problems for the patient with Alzheimer's disease includes decreased memory and cognition related to the neuronal degeneration in the brain, potential for injury or accident due to wandering or inability to ambulate independently, and also potential for elder abuse by caregivers due to the patient's prolonged progression of disability and the patient's increased care needs. Priority for the patient with Alzheimer's is safety. Safety, safety, safety. It's huge. Chronic confusion and physical deficits place the patient with Alzheimer's at a high risk for injury, accidents, and elder abuse. The patient with memory problems benefits best from a structured and consistent environment. Many things, including physical illness and environmental factors, can exacerbate the signs and symptoms of Alzheimer's disease. One way to approach managing the patient who has Alzheimer's disease is cognitive stimulation and memory training. This reinforces or promotes desirable cognitive function and facilitates memory. It includes pet therapy, using pictures of family and friends, encouraging reminiscing, placing a picture of the patient on their room door, so when they're walking down a hallway and every door looks the same, they can recognize their door. Keeping environmental stimuli to a minimum. Not having pictures that could be interpreted as scary. A quiet environment is important. Again, decreased stimulation. It also can help prevent disturbing sleep, which is important. Decrease nutritional intake. And then changes in the blood pressure and pulse and feelings of increased stress and anxiety can occur if they're in sort of a chaotic environment. So we want to try and keep things quiet. We want to keep objects in the same place. Daily routine, communication boards, clocks, single date calendars. The single date calendar is nice because they can look at exactly what today is, right? It's not a calendar for the entire month of January and they have to figure out what day it is. And keeping things in the same place will help them, right? Because they're used to where things are. And they can be very traumatizing if they're used to always having something special notebook or whatever it may be in a certain area, and they go to find it and it's not there. That can be very difficult for them. Early in the disease, we're going to use reality orientation. And what that is it's frequently reorienting the patient to the environment, reminding them what the correct day and time is, who they are, who you are, who their relatives are. So reality orientation is reminding them of what really is going on or what really is happening, who's who, what day is it, what's what, all that good stuff. Later, so as the dementia progresses, we switch from reality orientation to validation therapy. Validation therapy acknowledges feelings and concerns. It recognizes the patient's feelings and concerns without correcting them. So let's say they ask where their daughter is or where they're coming, and the daughter has been dead for 10 years. You wouldn't reorient them and say, oh no, your daughter died 10 years in late Alzheimer's disease. You would ask questions. I'm not sure. I haven't seen her. Where does she work? What is she wearing? When does she usually come by? So you're validating the patient, but not reorienting them to reality. As the disease progresses, the patient's ability to perform ADLs decreases. We want to encourage the patient to perform as much self-care as possible and to maintain independence and daily living skills as long as possible. Adaptive devices such as grab bars in the bathroom, elevated commodes, or adapted eating utensils may help the patient maintain independence in grooming, toileting, and feeding. A physical therapist may prescribe an exercise program to improve physical health and functionality. For a patient who's continent, we want to offer bathroom, bedpan, or urinal every 2 hours to help encourage them to continue to be continent. With Alzheimer's disease, they may forget that it's inappropriate to wet the bed. They may get the sensation they need to urinate and they just urinate. So by toileting the patient every 2 hours, there's it would be less likely that the patient will experience incontinence when they normally are continent. We want to encourage the patient to drink fluids. Sometimes people are, especially older adults, are fearful of incontinence, so they don't want to drink, but we know that's a bad thing. So we definitely want to encourage the patients to take fluids. And again, when people get older, they have less of a drive to drink. The thirst sensation seems to decrease. So we want to always be reminding our older patients to go ahead and drink fluid if it's not otherwise prohibited for them. We want to avoid the use of restraints, including side rails, because injury can occur when the patient is trying to get out of bed or get out of the restraints. Instead, we want to use frequent surveillance, toileting every 2 hours, and other strategic measures to prevent falls, like clearing the path or having a bedside commode if the patient's weak. We want to promote relaxation before bedtime, so anything to reduce stress and promote relaxation, whether it's turning off televisions and music, if the patient likes a massage, anything like that before bed. We want to use redirection by attracting the patient's attention to promote communication. So keep the environment as free from distraction as possible. Speak directly to the patient in a distinct manner. So you don't want to have your back to them and sort of talking to them while you're doing other things. They need to know that you're talking to them. Sentences should be clear and short. Remind the patient to perform one task at a time and allow sufficient time for completion. Regarding medications used to treat Alzheimer's disease, the first classification we're going to start out with is cholinesterase inhibitors. They're approved for treating Alzheimer's disease symptoms. They work to improve cholinergic neurotransmission in the brain by delaying the destruction of acetylcholine by the enzyme cholinesterase. So again, when you see that ASE, you're looking at an enzyme. This classification, cholinesterase inhibitors, is inhibiting the enzyme. This makes sense that this classification of medication is used to treat Alzheimer's disease because in the beginning we talked about the problem with Alzheimer's is decreased acetylcholine. So by taking a medication that inhibits an enzyme that breaks down acetylcholine, it allows more acetylcholine to be available. So it delays acetylcholine destruction by cholinesterase, which slows cognitive decline. None of these medications are a cure for Alzheimer's, but they can slow the progression. So that's important to know. Your prototype cholinesterase inhibitor is rivastigmine. Memantine is your prototype NMDA receptor antagonist. Overexcitation of NMDA receptors by the neurotransmitter glutamate may play a role in Alzheimer's disease. This drug blocks excess amounts of glutamate that can damage nerve cells. It is indicated for advanced Alzheimer's disease. We've talked about depression being associated with Alzheimer's disease. So antidepressants can be prescribed. SSRIs, the prototype you want to know is sertraline, is often used. Tricyclic antidepressants, such as amitriptyline, should not be used because of their anticholinergic effects, especially for older adults. And remember, anticholinergic effects, we're talking about increased confusion, urinary retention, constipation. Psychotropic drugs, also known as antipsychotic drugs, should be reserved for patients with mental or behavioral health problems that sometimes accompany dementia, such as hallucinations and delusion. These drugs are sometimes used incorrectly for agitation, combativeness, and restlessness in the patient. Psychotropic drugs are considered chemical restraints because they decrease the patient's mobility and the patient's self-management ability. Therefore, most physicians recommend that they be used as a last resort and with caution in low doses for a specific mental or behavioral health problem. We want to take measures to prevent the patient from becoming injured or having accidents. We want to prevent the patient from becoming lost, so they may have ID bracelets. We want to assign them to rooms that are easily monitored, so you wouldn't want your Alzheimer's patient at the end of the hallway, down by the elevator or the stairs. You'd want them close to the nurse's station where there's going to be frequent traffic, people that are able to look in on them. Alarm systems can be used, so when a door opens, it alarms to let the staff know that someone has opened a door. Frequent walks can help decrease restlessness. We want to keep them busy with structured activities, so whether they're craft time or whatever it may be in a long-term care facility. Even in the hospital, you'll frequently see nurses give the Alzheimer's patient a pile of washcloths or hand towels to fold, just to keep them engaged and active doing something. Make sure you speak calmly, redirect the patient, right? So if they're just stuck on the fact that they want to go to the elevator and that's where they need to go and that's where they need to go, you don't want to argue with them. It's not going to accomplish anything. You try to redirect, you try to change the topic. So they want to go to the elevator and then you look and say, oh my gosh, look at the time, it's lunchtime. Have you thought about what you're going to eat? And you try to get them onto a different topic. Do not argue with the Alzheimer's patient. A lot of times too, for the patient who has an IV, you can wrap the IV with gauze so they can't see it and want to pick at it and pull it off. That can be helpful. And then late in the disease, the patient may experience seizure activity. If the patient's cared for at home, we want to teach caregivers what action to take when a seizure occurs, and there may need to be seizure precautions in the hospital setting. Patients who are cared for at home are at high risk for neglect and abuse. Patients with mild dementia may not report these concerns for fear of retaliation, and those with severe dementia may not have the ability to report the abuse. Be sure to ask questions such as who cooks for you, do you get help when you need it, how long do you have to wait to use the bathroom, and it may help you get information that the patient is not willingly providing you. Families should seek legal counsel regarding guardianship and durable medical power of attorney. And we also want to watch for caregiver burnout. So if you have a person that's caring for a patient with dementia, it's extremely challenging and on a daily basis can wear you out. So there's something called respite care that you want to make sure caregivers realize exists out there. So respite care would be using a facility to give the caregiver a break. So I take care of my grandma 24/7, but I either need a break or I have to go on vacation. I need some time to myself. I can look into getting respite care for grandma. She can go stay in a nursing home for however long, or there's also daycares too. Elder daycares where the patient goes out and does activities and it gives the caregiver a little bit of a break. So just a quick review of what we want to make sure we're teaching our patients and our caregivers. We want to make sure caregivers know about respite care. We want to review ADLs and talk with occupational therapy about adaptive equipment if that will help the patient. Create a diet plan. Seizure teaching if necessary. Make sure caregiver and patient, if the patient's still able to understand the medication, how it's supposed to be taken, and what side effects they might want to watch for. We want to make sure the patient is exercising to maintain mobility. We want the environment to be uncluttered with hazardous items removed, and then safety precautions in place, such as handrails and night lights, and then alarms and locks as needed to keep the patient safe. We want to make sure patients, especially caregivers, are aware of healthcare resources for those with Alzheimer's and those caring for a patient with Alzheimer's. So evaluation or reflecting, how do we know that we're doing a good job taking care and treating our Alzheimer's patient? Patient will maintain memory and cognitive function. And again, there's no cure for Alzheimer's disease, but a slower progression of the disease is desired. Patient will remain free from injury and have a safe environment, and caregivers will manage stress and strain to prevent elder abuse.